Hi, everyone, and welcome to Massive Bio's Pediatric Cancer event. I'm Fiona Evans, the lead patient advocate here at Massive Bio, and I'm joined today by two pediatric oncologists, Dr. Jason Friedman and Dr. Theodore Leitch. And we are going to be discussing pediatric cancer, highlighting how genetics impacts treatment and clinical trials. So welcome, both of you. Thank you for joining us today. We appreciate you taking the time to be part of this event. So I'll do a little introduction. Dr. Jason Friedman is a pediatric oncologist and longtime pediatric advisor to Massive Bio. He serves as the inpatient medical director of oncology stem cell transplant at the Children's Hospital of Philadelphia. His clinical focus is blood and marrow transplantation and pediatric supportive care. And he has a particular interest in epidemiologic and translational research within pediatric supportive oncology. He also serves on several committees within the Children's Oncology Group and is also the PI and co-PI of collaborative institutional trials. Dr. Friedman has authored several textbook chapters and peer-reviewed articles on the supportive care of children with cancer, and has contributed to the development of clinical guidelines to standardize management of symptoms and toxicities associated with cancer therapy and stem cell transplant. So welcome, and you are very busy, so we really appreciate your time.
Thank you for having me.
Oh, thank you. And we are also joined by Dr. Theodore Leitch, an associate professor of pediatrics at the University of Pennsylvania, chair of the Rare Tumors Committee for the Children's Oncology Group, co-director of the Developmental Therapeutics Program, and director of the Very Rare Malignant Tumors Programs at Children's Hospital of Pennsylvania. Or Philadelphia, I should say. In these roles, he leads clinical and translational research evaluating novel, targeted, and immunotherapies for children with high risk and often ultra-rare cancers. He is active in early phase drug development nationally and internationally, with a particular focus on molecularly targeted therapies. As a member of the pediatric subcommittee of the FDA on oncologic drugs, national, international chair of drugs advisory committee, pediatric NCI COG match target and agent prioritization committee, and national and international chair of 3 children's oncology group therapeutic studies, as well as other industry-sponsored clinical trials. In particular, he has been a leader in the development of TRK inhibitors for children with TRK fusion cancers and serves as the global PI for several clinical trials of TRK inhibitors. So thank you very much. And again, welcome. And we appreciate your time. So let's jump right in. And Dr. Leitch, can you give a brief overview of assessing a cancer for mutations?
Sure. So mutations are changes in the DNA of a cancer cell, and they're what we think drive the development of cancer, the change from a normal cell in one's body to a cancer cell. And previously, when we've looked for mutations, most often that's been done looking for a single specific type of mutation in a single specific type of cancer. But more recently, we've gotten a lot better at using next generation sequencing, so broad sequencing to identify mutations across hundreds of different genes within an individual patient's cancer. And more commonly now, that's how we're evaluating for mutations rather than single specific mutations limited to a histology or a type of cancer. And with that, we've found that there's some alterations that can predict response to specific therapies across different cancer types. So the same mutation can be present in different types of cancer and can lead to response to the same type of therapy, even though there's different types of cancer. We're also learning more about the different types of mutations that occur in cancer. So can be specific mutations called fusions, for example, that you have to look for in a different way. And so we're developing more complicated assays to try to identify all the different types of mutations that are present in one's cancer. And more recently, we've actually started looking at cancer mutations from the blood of patients. So previously, cancer mutations have always been identified by taking a biopsy of a tumor and looking at that in the laboratory. But now for some mutations, we can actually identify them from a blood sample, from DNA that leaks out of the cancer cells essentially into the blood, allowing us to follow changes in these mutations over time without having to do repeated biopsies of patients.
Interesting. Okay, great. Dr. Friedman, what is the difference between testing a child's genetics versus the genetics of the child's cancer?
That's a really excellent question, and one that a lot of people ask, and I'm glad it was asked. As you all know, we're made of DNA, as Dr. Leitch alluded to, and that is the genetic material that sort of codes for our proteins and everything that makes us up. But however, there are times when that is what leads to cancer because you have certain genetics that predispose you to a cancer. But that's a very rare situation. Those are called predisposition syndromes. More commonly, we test for the genetics of a specific tumor. So if your child is diagnosed with a tumor or a cancer, we will look to see what the genetics of that particular cancer cell is. And the reason that that's important to differentiate is what we find in the cancer cell is not necessarily what is in your child, the rest of your child's DNA. And so we're looking for specific things that could help us treat the cancer, as Dr. Leitch alluded to, that we would want to target on the cancer cell specifically. Again, there are times that the same mutation might be located in what we call germline, which means it is part of the patient and maybe the cancer. But most of the time, we're looking at separate pieces where it's on the cancer cell in and of itself. And this is really helpful now in with modern technology to know how we're going to treat a cancer. And I will say that if patients are diagnosed with aberrations or problems in their germline or in themselves, we think differently about those patients, and their treatment might be slightly different because some of those patients may not handle chemotherapy or other treatments with the same toxicities. They may have more or other risk profiles. So it is important to understand we're testing the patient versus the tumor. Most of the time, the treatment is dictated by what the tumor is showing. And as we'll talk about, these trials really focus on the results of those type of testing.
Excellent. Okay. So the importance then, there's a big importance in having these tests done. And, how would a caregiver go about that for their child?
Excellent. So most of the time when a child is seen by a pediatric oncologist, they are going to get many of these tests done automatically. Adult medicine is a little different than pediatric medicine, but we have ironed out a lot of the ways in which we use this upfront. And so the child may get a biopsy, whether that's a bone marrow biopsy or a biopsy of a mass or a tumor. And not only is somebody going to look at that under the microscope or a pathologist to see what type of cancer cell that is, it's going to go through many of the things Dr. Leitch alluded to. So they're going to look at mutations. They're going to look at certain genetic fusions. They are going to do this as part of the standard workup for cancer. We also often send out panels of tests to other companies that do much broader arrays of cancer-specific mutations. And so in general, cancer centers are very savvy at doing this and will do it automatically. In the adult world, it's not the same. You often have to do that as a second step. I know that companies like Massive Bio or other centers are able to help guide you as to what type of testing your child may need if they haven't had it already. And your child's doctor can certainly do the same. But again, the reason these are important is it may guide therapy. It may say there's a specific agent for your child. And very particularly important if a child is progressing through upfront therapy or they're relapsed. because the standard therapy at that point we know has failed, and we need to move on to something more sophisticated and more savvy. And that's when getting these tests done. And so your consultation with an oncologist or a second opinion or through something like Massive Bio could guide you as to what you need done that you may not have already had.
Okay. Yeah, that makes sense. Good. Okay. So why are genomics and these mutational analysis so important in treating cancer now?
Well, I think that you're getting the flavor and the sense from what Dr. Leach and I are talking about, that treating cancer is really not like the olden days. Even in the last 10 to 15 years, we've moved from what I would call the kitchen sink approach, where you have cancer and we're just going to throw a ton of chemotherapy or a ton of radiation at you, hoping that some of the cells get killed and that the patient becomes cured. But we realize that the side effects of those treatments and the long-standing problems of those treatments thereafter affect that patient for life. And so that approach is not a good approach for everybody. Are there tumors still today that require very intensive therapy and we don't know better? Absolutely. But there are many tumors for which knowing a very specific mutation or a fusion can reduce the amount of therapy that that patient needs. We can do something also called precision medicine, where we can say, your tumor shows this signature and you would benefit from this medication and put you on a certain pathway. For other patients, it may say, your mutation is very different and you need to go down this pathway. And so precision medicine is taking the agents that are specific to what the tumor is showing us, the behavior of how the tumor is acting, and giving drugs much more targeted. The benefit of this is that there's a higher chance of a response, that the tumor would hopefully go away, but also that you're going to dramatically decrease the amount of toxicity, because you're only giving therapy that the patient requires or needs instead of a boatload in hopes that you'll get a response. And that is really the way the field of oncology is moving, because we've learned very much that it's not about just getting the patient through the experience now. It's about setting them up for survivorship and living a healthy, productive life thereafter. And our little children with cancer really have a long life ahead of them, and we owe it to them to make sure that the treatment is as tailored and as low toxicity as possible.
Yeah, that's great. Thank you for that. So, Dr. Leach, I'll jump to you here. Maybe you can explain to us what is a clinical trial, because I think that's where we're heading with all of these great advancements in medicine.
Yeah, so that's an excellent question as well. So there's different phases of clinical trials, but in general, a clinical trial is where you're testing a new drug that hasn't been tried before, or a drug that's been tried for one group of patients in a different patient population, to really understand how well that drug works, what's safe about that drug, sometimes what the right dose of that drug is. And it's really studying this in a rigorous way to try to understand best how we use these therapies. As I mentioned, there's different phases of clinical trials. So many times children with cancer are often enrolled on a phase 3 clinical trial when they're newly diagnosed. And that's oftentimes comparing the standard of care therapy with a slight adjustment to the standard of care therapy that, as Dr. Friedman mentioned, may either make it work better or have less side effects. But then when we get to the space where that doesn't work and the cancer has relapsed or progressed through that, then we often do early phase clinical trials. So phase 1 or phase 2 clinical trials, where we're really trying to learn about new drugs and about the safety of these drugs. Oftentimes, these are drugs that have been used in adult patients and have shown promise in adult patients, and now we're trying them in children, although sometimes we do new studies of brand new drugs in children when there's a different target than there is in adult cancer. So it's really this process of learning about these drugs and understanding the drugs and their effects in patients.
Great. And, as you know, Massive Bio, we help patients to find those clinical trials. So oftentimes patients are in medical facilities that may not offer the option of clinical trials. And for those patients, and even patients and providers that have exhausted their options, locally, we help patients to locate and enroll into clinical trials. We use a artificial intelligence-based technology to sort through all of the available clinical trials to find clinical trials that the patient is eligible for based on their diagnosis, medical and treatment history, and also their location, so that they can, easily enroll, share that information with their doctors, and, be provided every option available to them. So in terms of clinical trials, are there clinical trials available for specific biomarkers that are identified in the testing? And what are some of those biomarkers?
So certainly recently, a majority of our clinical trials have now focused on using biomarkers to guide selection of therapy. And it really is, Dr. Friedman mentioned, I think in my opinion, a way to be smarter about the drugs that we're studying and understand which drugs may be most effective for which patients. So there's a few different classes of mutations for which we have clinical trials, and I'll just run through those briefly here. The first is for what we call kinase fusions. So these are mutations that are a specific kind of mutation where two genes that aren't supposed to be touching get stuck together inside the DNA of a cell. And that turns on one of these genes and can be a very strong driver of cancer. The first of these was identified really was a kind of leukemia called Philadelphia chromosome leukemia. And we've developed an inhibitor for that that's really revolutionized the care and is now standard of care for every patient that has that type of leukemia. But more recently, we've seen these same type of changes in different kinds of cancers, solid tumors, as well as leukemia. And a lot of different drugs have been developed to block these mutations. So some of the specific alterations that we've seen are what we call NTRK gene fusions, or fusions of the NTRK 1, 2, or 3 gene. And there are TRK inhibitors that have now been both FDA approved for children with these mutations, and others that are being studied for the same type of mutation. Similarly, there's ALK fusions, which have also been FDA approved for some cancers that have ALK fusions and are being studied across a wide range of other cancers, and ROS1 gene fusions, which are similarly being studied across a number of different clinical trials. And what we've seen is that while some of these drugs are still in clinical trials, those where there's data have shown really very promising efficacy with very, very high numbers of patients that respond to those therapies. And it's been really exciting to be part of the development of those therapies personally and see some of my patients be able to benefit from those treatments. The other sort of big class of mutations where we've seen efficacy is what we call high tumor mutation burden tumors. So these are tumors that have lots of different mutations, where we actually have learned that the immune system may be able to fight those tumors because of all these mutations show new antigens that the immune system can recognize. And so there's, again, an FDA-approved drugs for high tumor mutation burden tumors as well as clinical trial options. And then there's a lot of other studies that are using other biomarkers beyond those to try to learn better how we target all these different alterations. There's studies run through the Children's Oncology Group, for example, Pediatric Match, as well as another number of other industry and single site or single sponsor studies that look at various other specific mutations and try to match therapies to those alterations.
Excellent. So seems like there are more and more options, which is great. So in terms of clinical trials, what treatments are used in those in clinical trials to target, those biomarkers?
So for many of these biomarkers, it's medicines that are used that are very different than standard chemotherapy. So standard chemotherapy, like Dr. Friedman mentioned, are drugs that really just kill cells that grow very quickly. And so that's why they have all the side effects of losing your hair and having low blood counts, is because those are fast-growing normal cells. Mm-hmm. These are very targeted therapies that tend to inhibit one or only a small number of genes within a cell, and are really designed to try to specifically block what's driving that individual patient's cancer. So some of those agents are kinase inhibitors, drugs like larotrectinib or entrectinib, repotrectinib are some of those that are being studied for TRK fusions, for example. And these are all oral drugs that you take as a pill or as a liquid that have very different side effects and much fewer side effects than you think about with the sort of cytotoxic standard chemotherapy. Some of the others are, as I mentioned, immune-mediated agents designed to turn on the immune system. And those are often given through an IV infusion, but again, don't have the same sort of spectrum of side effects that you think about with standard chemotherapy.
Okay, great. I know we're talking specifically about pediatric clinical trials. Is there a specific age limit to pediatric clinical trials?
It does vary from trial to trial. There are some trials that go all the way down to birth in terms of the youngest age, and some trials that actually span the entire age range that go from birth all the way through, elderly adult patients. For many of these trials, eligibility is 1 or 2 years of age, but it depends on the specific trial. But for these pediatric trials, most children would be eligible. Age is not generally something that excludes patients from these studies.
Okay. And how would someone go about getting their child enrolled in a clinical trial?
I think that's a great question. And just one thing to add to Dr. Leitch's prior answer is that not only is age a factor, but all the other clinical parameters of a child's cancer and how they are and their liver function and kidney function and everything gets taken into account. So it's why you need a good center that can evaluate you, and whether you get there through your doctor or from Massive Bio or another similar group, you will go through a doctor screening process where they're going to look at all the parameters and or Massive Bio's algorithm, and will say, based on your function, you're this, you're that, you are or are not eligible. And it can be often frustrating because there are very few slots on many of the clinical trials, and it could be one little number, or your kidney test is just out of normal range. And so that could make you eligible or not. So just something to be aware of, that once you identify a trial, there are some steps that need to go through as a family or as a patient, and Massive Bio can certainly help, as well as your care team. I think getting involved in a clinical trial depends on what is the clinical trial for. And I say that because Dr. Leitch told us that sometimes clinical trials are not just for relapse or progression, they are for the minute you're diagnosed. Clinical trials are the way we get information and develop standards as to how to treat children. And the treatments we have today harken back to research that was done in the 60s, 70s, 80s to know what is the right therapy for a child. And so I want families to understand that just because you're being proposed to go on a clinical trial does not mean you have advanced cancer, doesn't mean you have progressive or relapsed cancer. You may be on a trial where they're looking at whether 8 milligrams or 9 milligrams of the same known drug that helps a cancer is better or worse. And so one shouldn't be fearful of a clinical trial. Again, many pediatric cancers, unlike adults, are treated on a trial. And why is that? Because we need to pool patients together to get meaningful data. In the adult world, there are thousands and thousands of patients with cancer, unfortunately, but it's true. And so getting data about what works and what doesn't is much easier. In pediatrics, the numbers are so small and cancer is so rare that the only way to know if something's working or not is to pool numbers from various centers. And so clinical trials are the infrastructure to do that. So again, working with Massive Bio to screen your child and help you find a center that has a trial open, or your own care team back at home, they can certainly do that. But really using the tools, your genetic testing, your clinical picture, the genomics, sort of the course you've had so far and the response to treatment that you've had so far, all factors like this really are very important to determine what your next steps are. And if it is a clinical trial, there are the options, and should definitely talk to your provider about it, but there's ways to get on those trials.
Yeah, that's great. And it is important to mention, I think, like you said, there's unfortunately a misconception, regarding clinical trials. in this day and age now, there are so many advances that, you could be receiving, a life-saving therapy, or, something that, is used to help treat others. It's just, they're very important to everyone. And, we certainly want everybody to have that opportunity. And like you said, you can get these information about clinical trials through your local provider, or you can reach out to Massive Bio, and we can, work with you and your provider to provide you these options. Will there be trials available at every hospital, or how would a parent go about finding a clinical trial for their child? Dr. Leach.
So again, I think there's different phases of clinical trials, and so the answer to this is going to vary a little bit. The Children's Oncology Group does conduct clinical trials at more than 200 sites across the United States, and the vast majority of children with cancer are treated at a site with Children's Oncology Group trials available. So there are often clinical trials, as we mentioned, that you would be eligible for at the very first diagnosis of your cancer. But these clinical trials that we've been talking about more recently today, where we're focusing on patients whose cancer isn't responding like we like it to that therapy, or to very specific targeted inhibitors, may not be available at every site. And those trials are often limited to a smaller number, a handful of sites across the United States or across the world. And so maybe something that you have to consider traveling for. As was mentioned, there's a number of ways to identify those trials, and then you'll often have to have your records sent to one of those sites to be reviewed to see if, as Dr. Friedman mentioned, you would be eligible, and then would need to travel to those sites. There's a number of ways you can find those trials. There is a national registry of clinical trials, clinicaltrials.gov. I would say from my perspective, it is a little bit challenging to use to identify the right trial for each individual patient. Your provider can also reach out to other providers across the country, or you can use a service like Massive Bio that can help facilitate some of those interactions.
Yeah, I have to agree that clinicaltrials.gov is a great resource. It is a little tricky to navigate. We use that ourselves here at Massive Bio to identify trials. And so we understand the challenges, and when families are going through a cancer diagnosis, the last thing they want to do is have to deal with that. So we're happy to help with that. We sort through all of those trials listed on clinicaltrials.gov to provide a listing of eligible trials for patients. So it's good to know that there are other options, besides your local facility that can assist with trials. So if a child did enroll into a clinical trial, how would their life be different versus, just receiving the standard of care treatment?
That's a great question. I think, and both of us probably have different opinions or similar to some degree, but I think that, again, if your child is on a clinical trial that is part of the upfront, this is, you're diagnosed with X and this is how we treat X, it's not going to look much different than being at your home center and getting the medicines and chemo, radiation, whatever is required for that tumor. Whether or not you're on a trial looks like a lot of paperwork, but it doesn't change what your child actually receives. It still requires visits to clinic. It requires maybe inpatient stays at the hospital, things like that. If you're on a clinical trial, and I know there's a question which we'll get to later about different types of clinical trials. If you're on a clinical trial that is a new agent or a more experimental agent that hasn't been tested in children that much, or it's a new time being tested in children, it is going to be a different experience, because in that case, we're looking at the safety of the drug. We're looking to find a dose of the drug. And so there's going to be maybe more lab draws to try to see what is the blood concentration of that drug. It may require more visits to clinic, more monitoring for side effects and symptoms, because again, if it's new in children, we need to document all of the side effects and things that you're getting. We want to get the dose right. again, with clinical trials, because they may be located far from your home, oftentimes the drug company may have a pot of resources to help families with expenses of travel and housing. And your social worker at your home center may be able to help you with that. I know that as part of clinical matching, Massive Bio often has access to the pharmaceutical help and can sort of help the families. Again, we, as physicians, we're not involved in that, but we want to support you in any way possible. And I would ask your social work team or anybody that you're working with, how can you help me? Because it may be far, it may be required to get there. I did see a question, and we'll talk more about it, but if your home hospital doesn't have a certain trial, it is certainly worth asking if they plan to open it. It does take a while to get trials open, so it may be in the pipeline to be opened. If it's not, or there's no plan to do it, then again, we would try to help you find another center, or your home team can help you find a different center. But a lot of streamlining is the goal of sort of the Massive Bio platform.
That's right. That's correct. We try to do all of the work, and we can also help with sometimes opening up a site close to you if there isn't one available. That doesn't happen every time, but it is a possibility. And so talking about trials with your providers, I think, is key to being provided that information and knowing all of your options.
Yeah, and Ted, Dr. Leitch, I'm just curious, are there other thoughts you have about that? Like, what does it look like day to day living, being on a clinical trial from someone who runs many and involved often with rare tumors where the trials are, very few patients on a trial? Sort of, what does that look like day to day or week by week?
Yeah, I agree with you completely, Jason, that I think it really depends on the phase of the clinical trial. And there was a question about phases of clinical trials, which maybe I could just go through briefly. But for a phase 1 clinical trial, where our goal is to find the dose that's right of the medicine in children, it does definitely involve more visits than you might be used to as part of upfront therapy, and more visits than would be required for standard of care, or longer visits than would be required for standard of care. Because as you mentioned, we often have to check the level of the drugs in the blood, and we need to do other tests to look for side effects of the medication. And so often for that first month of therapy, you would be coming at least weekly to see your doctor, and sometimes may need to stay in the area for up to that first month of therapy, depending on the trial. After the first month, the sort of required level of observation backs down to some extent, because we now have some understanding of how your child is tolerating, is doing with the medicine. So it backs down, but it's still more involved. Whereas, as you mentioned, for other, phase 3, which are the sort of large children's oncology group studies for all newly diagnosed patients, those clinical trials generally look very similar to standard of care, with, as you mentioned, sort of small tweaks to the treatment schema, but a similar amount of visits and other things that you would experience.
Okay, great. So I think we're wrapping up here, but one more question. When considering a clinical trial for a parent, when they're considering that clinical trial for their child, does that mean that it's their last option?
I think we've tried to highlight that is a myth, and sort of important to know the clinical trials are very important to get research advanced and to get better cures ahead of us. Again, most clinical trials are standard of care, trying to make some tweaks, make the treatment even better. A really great book called Emperor of All Maladies sort of walks through various clinical trials and sort of talks about cancer in a very unique way. And I recommend that for people who want to learn more about this. But I think that if a clinical trial is for someone who's relapsed or progressed, every time you try a new agent and it doesn't work, it gets harder and harder to get that cure. And so it certainly could be that certain clinical trials are for patients who are relapsed, or their disease is what we call refractory, which means it's just not responding to any of the other therapies that have been put before it. And so while some clinical trials are for those patients, many are not. And so shouldn't be worried unless you should have discussions with your provider about what is this treatment? Why are you recommending it? And ask directly, is this because my child's failing the other therapy, or this is sort of the standard of care? Those are really important questions to have, but we can't make advances if we don't do things in the structure of a clinical trial. We don't and we cannot just write medication on a prescription pad, random drugs and chemotherapy that we want, because we don't learn that way. We don't do a service for the child that way, and we could actually cause more harm that way. So it's very important that all things are done this way. One of the very hard things, and I'll just leave with this, and then we can do some questions, is some clinical trials, like the phase 1 that Dr. Leitch alluded to, is not intended to specifically provide benefit for the child which is receiving the medication. We hope that it will provide benefit. But the phase 1 schema is really to find a dose that's safe and tolerable for the next generation of trials, so that we can use that drug and hopefully cure children. We are using drugs that have some data, maybe in the lab or in other adult tumors, that it may be helpful, but you can never promise somebody that when we put you on this trial or this drug, it's going to directly benefit that child. We all certainly hope so. But the goal of a phase 1 trial is really to make sure it's safe. And then we move it into trials where we test it against specific tumor types. And in those trials, yes, it is challenging to find any drugs because the prior therapies have not as well.
Right. Okay, so we do have a few quick questions. One question, how long do two clinical trials last?
So maybe I can start with that. And I think there's two aspects to that question. So for an individual patient, the length of therapy on a clinical trial will vary dramatically, again, depending on the phase of the clinical trial and the structure of the clinical trial. So some trials for newly diagnosed patients with leukemia, for example, may last 3 years, where patients are on treatment for that long on a clinical trial. Whereas others, like these new trials that we're talking about, really the length of time varies, and it depends on how the patient or the child is responding to the therapy. So for most of these trials, the patient can stay on the therapy for as long as they're benefiting, meaning their tumors are not growing or their cancer is not getting worse. And as long as they're not having side effects that are too severe, that means we would have to stop. And so it really varies depending on the patient and how they're doing. But like I said, it's dependent on the phase of the clinical trial. The actual whole clinical trial is a different question, and that clinical trial enrolls anywhere from a couple dozen to thousands of children, and that can last for many more years. But that's not what an individual patient experiences.
Got it. Okay. And one more, how are clinical trials, how am I paying for a clinical trial is the question. So, are there extra costs, or how does that happen and work?
So there are so most clinical trials, if there's an investigational and experimental medication, usually that experimental medication is provided for free as part of the clinical trial. But usually we still bill the insurance company for the routine parts of the care, the things you would get even if you were on standard of care therapy. So often that's some labs and the scans, those kind of things are done as routine care. But again, it was something that you should ask the person if you were talking about a clinical trial about the specifics. The other costs, things like travel to the site, if it's not at your local site, are something that may be supported by the clinical trial sponsor. Some sponsors have money available for that, but some don't. And so for some of those may be also added costs to the patient and their family.
And those are things that are discussed, at the time. When the trial is presented, and the families can discuss that either with the site itself or with the physicians, right?
Exactly.
Okay. Okay, well, I think that's it for us today. Thank you again, both of you, for joining.
Fiona, I do see some questions in the comments that maybe we can have a couple of minutes to address.
Sure.
I think someone asked a great question about different trials, different phase trials. I think Dr. Leach has helped with that. I think there's a great question here about, should parents also get genetic testing? I think that's a great question, and that goes back to what mutation we are finding or what syndrome we're concerned about. So if the tumor has a certain mutation or a certain fusion, and we think it's wholly within the tumor, not related to the patient's own DNA, so it's not germline, then generally not. There's no further testing that needs to be done. If we find in a tumor a certain mutation that makes us a little worried or a little concerned that maybe there are other family members who could be affected, and it's not just in the tumor, like P53, Li-Fraumeni syndrome, other things, we would consider that the parents and other siblings might want to get tested. And it's not only for the benefit of the patient at hand, but maybe for that other sibling or that parent to know if they need to get other testing or things done, routine checks. The other time this comes into play is if this patient needs to go to a bone marrow or stem cell transplant, and that sibling might be a donor for the patient at hand. We would want to make sure they don't have the same mutation or any problem. But in general, cancers that are caused by spontaneous mutations for the most part, and finding a familial predisposition or a reason in somebody's own DNA why they got cancer is incredibly rare. And so there's no routine testing that parents should undergo automatically. But an excellent, excellent question. Great. Maybe, Fiona, you could take this one. I see. How long would it take for Massive Bio to enroll somebody on a clinical trial?
Okay, yeah. So for Massive Bio, we first request the patient's medical records so that our nurses can review them and process them in our artificial intelligence-based platform to sort through all those available clinical trials. Typically, it takes about 72 hours to process once we have received the medical records. So generally, we get the medical records within a day or two. Sometimes, it can take a little bit longer than that, but at the most, you're usually at 5 days if it does take longer for the medical records. So it's a pretty quick process, and we support the patients and their families both with patient advocate support, and also our nursing staff is available to help patients and their families as well.
I see one other question has come in, and it's an excellent question, and I'm curious to see if Dr. Leach has any specific comments on this, but do we have anything about AYA population and how to increase clinical trial enrollment in this population, and sort of specifically maybe we can, Fiona can touch base on what Massive Bio might be doing to try to get to this population. But maybe from a just pediatric oncology standpoint, we all know that AYAs, or adolescents and young adults, sort of fall in this gray zone. Sometimes they fall in pediatric space, sometimes they fall in the adult space. So Dr. Leach, I'm not sure how you see AYAs or where they generally fall on the clinical trials that you're dealing with.
So it's an excellent question, and I think it's something that we all recognize we need to do better on. As you mentioned, the adolescent and young adult population is underrepresented on pediatric oncology trials, and they're also underrepresented on medical adult oncology trials, and they have really been slipping through the cracks. There have been a number of efforts to try to improve this. I think one of the biggest is that recently the FDA has been encouraging clinical trial sponsors to allow patients 12 and older to enroll on adult clinical trials using the adult dose of the medication. And so that's provided additional access for these patients, and recently actually resulted in approval of several targeted therapies for patients 12 and older adolescents and young adults 12 and older that might not have previously been included in the initial approval when it was just for adults. So I think that is very helpful, but we still need to work to help these patients and their families identify the right clinical trials and reach the right sites. But at least now they have trials for which they're eligible. And we see that some of those trials are now opening in pediatric centers as well to get these patients access to this therapy, in addition to being open at sort of medical oncology centers.
Yeah, and I'll agree with you there. We are seeing that a little bit. It's not enough, of course, but we are seeing that, and our nurses are always available to help with those types of questions and issues that pop up.
Yeah, and I would just add one final thing is that when we see patients in the office or in the clinic, or they come through the pipeline here at Massive Bio, I think that everybody's approach would be similar. It's about putting the patient where they actually belong. The right trial for the right patient. If a trial is not the right answer for a patient, then they shouldn't be there. Right. If they should, they should. And that's the kind of information that obviously your care team at home, and sort of when we see patients in either a second consultation or whatever, it is all about your child. And so the decisions are made with that in mind. And if treating young adults as adults is the right answer, then it will be great. If putting them on a more pediatric trial is the answer, then that's where they will go. And so I think ironing out this gray zone is very, very important. And it'll probably open the door for other trials in the future, depending where, based on the drug in particular.
Yep. All right. I don't think there are any more questions. None that I see here. So I think that wraps it up for us. Thank you both so much for taking the time out for this event today. And thank you for everything that you do for cancer patients and their families. It is greatly appreciated. Thank you so much.
Thank you for having us.
Yeah, thanks for having us. And, if there's families and people out there that are interested in certain topics related to pediatrics and oncology, please let Fiona know, or put it in the chat box, because we have other colleagues that we work with, and there may be people that can answer your questions like this. So we want to get the information to you.
Yes. Thank you.
Have a great day, everybody.
Thank you. Take care. Bye-bye.